2024 till now, and is a leading infertility expert with a lot of publications. He's going to talk to us on protecting one's fertility and preservation and rejuvenation. Please, Dr. Professor.
Thank you very much, chairpersons, for your kind introduction. And I would like to take this opportunity to thank the EFS for their kind invitation. So today I'm going to speak on how we can protect one's fertility, preservation, and also rejuvenation. When we talk about the perfect balance, there are various factors which interplay in a very serene, miraculous balance in childhood, puberty, adolescence, and reproductive age to maintain fertility. And a small disturbance of this balance can have devastating consequences on one's fertility, which can have a major impact not only on the individual, but the family and the community. So, a large number of modifiable lifestyle factors contribute to subfertility, and these can be controlled and optimized to protect one's fertility. We know that the ART is moving at a tremendous pace, and I think it is time that we spread awareness of how young couples can protect and preserve one's fertility. When we talk of age, it only advances. We all know about the aging ovary and how it is inevitable, irreversible, with no evidence that this process can even be slowed, leave alone reversed. So a woman of 35 years is only half as likely to have a healthy baby as a woman of 25 years. And we know that 75% of women trying to conceive at age 30 will have a conception ending in a live birth within 1 year, which goes down to 66% at the age of 35 and a mere 44% at the age 40 years. But we never speak about the male age. We also know that the age advances in male. We know that advanced paternal age is associated with not only increased time to pregnancy and decreased pregnancy rates, and this can happen because of delayed marriages, postponement of pregnancies, and now we know that infants born to advanced paternal age are at a higher risk of premature birth, late stillbirths, low Apgar scores, low birth weights, high incidence of newborn seizures, and birth defects such as congenital heart defects and cleft palate. Now, fortunately, most of these congenital or chromosome defects can be found, but the gene defects that take place, which gives rise to increased likelihood of childhood cancers, autism spectrum disorders, and adult onset schizophrenias, are unlikely to be picked up in pregnancy, and this is known to be associated with advanced paternal age. We also talk about the maternal weight. We know that weight plays an important role in the optimum functioning of the reproductive system, and one of the major modifiable factors now in protecting one's fertility. Obesity is a worldwide epidemic associated with subfertility, anovulation, and menstrual dysfunction in women. But we don't talk about the weight of men. We know that obesity is also common in men. It adversely affects semen quality because of alteration and imbalance in the reproductive hormones, affecting sexual functions and thereby reproductive outcomes. And hence, when we talk about weight loss, it should be equally emphasized not only in the women, but also in the man. So we know that obesity is a disruptor of female fertility. It leads to anovulation, infertility, hormonal disorders, and the adipocytes act as an endocrine organ, releasing a large number of bioactive molecules which not only cause subfertility but is associated now with cardiovascular risk, coagulation disorders, and oocyte differentiation and maturation. We also know, as I said, that obesity in men is associated with an increased sperm fragment disruption. And now we know that obesity in men can be one of the reasons for recurrent pregnancy loss. So, the international evidence based guidelines on assessment and management of PCOS has also recommended that weight loss should be one of the main pillars in PCOS management with exercise and diet control. But this was known many years back when we looked at IVF outcome in PCOS women. We found that there was a higher miscarriage rate, and this was not really associated with any egg oocyte morphology or embryo quality or anything to do with the metabolic activity of the pre implantation embryos. It was solely dependent on BMI. And when there was a drop in BMI in the woman's weight, it gave her a better chance of getting pregnant and also carrying the pregnancy. But we have a large number of women who are on the opposite side of the spectrum, where their BMI is extremely less than 19, and they also come to us with irregular menstruations. And this is mostly found in women who have got anorexia, bulimia, body dysmorphic disorders. So, what they need in addition to medical management is intense counseling, psychosocial support, and proper management to optimize their weight. How do you counsel women about their weight? We know that a small change in the BMI can have a large effect on ART results. So, when the BMI is between 30 and 35, the ART outcome with all other parameters remaining same is reduced by 30%. And when the BMI is more than 35, the ART outcome is reduced by a massive figure of 50%. When we look at addictions, we know that almost 30% of men and 20% of women globally use some form of tobacco. And we know that the use of tobacco, particularly in men, has shown to reduce sperm parameters. We also know that cigarette smoking is associated with a prolonged and a dose dependent adverse effect on ovarian function, reduced pregnancy rates, even after treatment, as compared to non smokers. Now, there is a myth about e cigarettes and vaping. Most of the young crowd thinks that that is much more safer, but e cigarettes is an electronic alternative to traditional cigarettes. And although it is considered as a safer option, we must understand that it has shown to reduce sperm counts and also implantation rates in women who resort to vaping. What about alcohol? We know that alcohol in moderate or small amounts really doesn't affect fertility or increase miscarriages. But when there is binge drinking happening, we know that it is related to not only miscarriages but congenital defects in the babies. More worrying now is recreational drugs that are taken by couple around the time of conception or early pregnancy, and we know that this has severe effects on the baby. Occupation, some occupations involve exposure to hazardous conditions will affect both the male and the female. We know about call centers which work through the night, and perpetual night shifts affect the HPO axis in women. And there have been excellent studies done in India which have shown that those who perpetually work night calls have got irregular menstrual cycles and also reduced sperm counts, increased obesity, and cardiovascular problems. What about stress and infertility? Very difficult to say as the egg and the hen thing, but we know infertility itself can cause stress, but we are not very sure whether stress can cause infertility. But it has been shown that when there is extreme form of stress, like famines, cyclones, or some loss of job, it can affect. And that is why we now talk about relaxation techniques which are offered to the couple as a unit, which is known to reduce their psychosocial stresses. This can be with counseling, exercise, meditation, acupunctures, massage therapies. Comorbidities including diabetes, thyroid problem, endocrinopathies like hypercortism, pituitary disorders, genital tuberculosis, and other systemic illnesses are known to reduce fertility and should be looked into. More important is sexually transmitted infections, especially chlamydia and gonorrhea, in causing tubal factor infertility, can be preventing by educating couples regarding safer sex practices. I think it's extremely important to talk to the young uh, uh, generation as regards safe sex practices, importance of barrier contraception, timely treatment of STIs, awareness should be incorporated in adolescent education. How does the pill work? It works as a best fertility protector, and we know that the pill, although small, is very powerful but very much misunderstood. And the non contraceptive benefits of the pill include cycle regularization, treatment of menorrhagias, dysmenorias, endometriosis, premenstrual syndromes, and also for mild PCO patients. But we know that pill can protect against the development of functional cysts. It is helpful in PCOS and quite often helps to correct amenorrheas in women with severe weight loss, stress, exercise amenorrheas, and can prevent damage to the ovaries from radiation and chemotherapy. So it's very important to counsel couples to use pill. There are lots of women who do not want to conceive. We would put them on the pill so that to reduce the number of ovulations and perhaps conserve the egg. We now talk about a new generation on ice, which is fertility preservation, for whom, when, and how. We know that premature ovarian failure can be related to genetic and chromosome abnormalities and autosomal causes and autoimmune causes. Fertility preservation is one of the most useful methods when fertility failure is known, particularly after consequences of cancer, radiocytotoxic therapy, or even after surgical treatments, especially in severe endometriosis. And hence, it is important to talk about oocyte cryopreservation. There is good evidence that fertilization and pregnancy rates are similar to IVF ICSI with fresh eggs when these oocytes are used. And although there is very limited data yet, but there is presently no increase in chromosome abnormalities.
Excuse me, Professor Patki, I think
Yes,
time
to
is
half
finished.
a minute. And birth defects and developmental defects. So we can talk about oocyte cryopreservation. We can talk about embryo cryopreservation, about ovarian tissue cryopreservation. But it is as important to talk about sperm cryopreservation. Very easy, very cheap, and also should be offered to men who do not want to father children prior to the age of 50. Fertility preservation surgeries and ovarian rejuvenation is now done extensively with PRP, although there are contradictory reports and there isn't much scientific basis on this, but it is extensively used in uh, uh, patients with premature ovarian failures or with poor responders. I think AI can help us. We must understand as fertility specialists that up to now we have been only curing fertility. We need to talk about restoring fertility, which can be effectively done with gonadal transplantation, gene therapy to identify the genes that may be involved in, premature ovarian failure. And this is something that the Human Genome Project can help us, because if we identify the gene, we'll be able to do better. So I think it's very important that we not only talk about advances, but we need to tell the couple about how they can prevent infection, and they can preserve their fertility and preserve and use their fertility data. Thank you very much for the patience here.